So picture a nurse standing in a hospital room, and they're holding a standard lightweight canvas vest.
Just a totally ordinary piece of medical fabric.
Right. And usually, when we look at medical equipment, form follows function in this really unambiguous way, like a scalpel cuts tissue, a cast immobilizes a fracture.
Right, the object itself kind of dictates its reality.
Exactly, which is comforting. It leaves no room for interpretation. But the moment that nurse applies that simple canvas vest to a patient, all that clarity it completely vanishes. Depending on just a few invisible variables, that vest is either a basic, helpful, therapeutic postural support, or it is a highly regulated, legally perilous behavioral restraint.
Yeah, it really represents the absolute bleeding edge of clinical and legal liability.
Mm.
I mean, a single judgment call regarding that vest or a bed rail or a dose of medication can cross the line from standard care into civil or even criminal liability.
Wow, criminal.
Oh, absolutely. False imprisonment, battery. The margin for error is effectively zero.
That is wild. So if you are listening and navigating the healthcare system today, whether you're, an insider dealing with these protocols or you're just looking closely at how hospitals manage the people you care about, this dynamic flips almost everything you assume about patient safety totally upside down.
It really does.
And so our mission for this deep dive is to explore the incredibly high-stakes reality of restraints in nursing and healthcare. We're going to look at how they went from being this absolute default safety measure to a strictly legally restricted last resort.
Yeah, and we really need to look at the mechanics of why they fail, too.
Right. The physics of how they cause harm. And of course, that incredibly rigid legal framework that governs them today.
Well, and to start, I think the most important thing to grasp is that the defining metric isn't the physical object itself.
Right, like the vest.
Exactly. The Centers for Medicare and Medicaid Services, or CMS, their guidelines establish that a restraint is defined almost entirely by clinical indication and intent.
So it's about the why, not the what.
Precisely. To use your vest scenario, if that vest is placed on a patient with a severe spinal injury sitting in a wheelchair, and it's specifically prescribed to prevent them from slumping forward and making their injury worse.
Then it's just a standard postural support.
Right. It serves a targeted therapeutic purpose.
But if you take that exact same canvas vest and put it on, say, a post-surgical patient who happens to be confused from anesthesia.
Just to tie them to the bed so they don't wander off.
Yeah. Then it instantly becomes a restraint. Because now it's being used to control behavior and restrict movement. It actually really reminds me of prescribing a heavy narcotic.
Oh, that's a good comparison.
Right, because the exact same pill at the exact same milligram dosage is either a compassionate, highly regulated pain management or it's illegal drug diversion.
Yeah, the chemistry of the pill didn't change at all.
Exactly. The entire distinction rests on the physician's documented clinical intent and the specific diagnosis.
That captures the nuance perfectly. And, that line of intent gets even blurrier when you look at how the definition of restricting movement has evolved over time.
I mean, the rules have definitely changed.
Oh, massively. The most glaring example is actually the standard hospital bed rail.
Oh, yeah. This one surprised me.
Right. Because for the vast majority of the 20th century, raising all four bed rails was simply what you did. It was the unquestioned baseline of patient safety. You leave the room, you pull the rails up so the patient doesn't roll onto the floor.
Which, that seems completely intuitive, right? Until you actually look at the physics of a frail, confused patient trying to bypass them.
Exactly.
Because if an elderly patient is in a low bed with the rails down and they roll out, they fall, maybe a foot or two?
Yeah, they might get a bruise, maybe a minor laceration.
Right. But when all four rails are locked in the up position, that same confused patient doesn't just decide, oh, well, guess I'll stay in bed.
No, they try to climb over.
They attempt to vault over a metal barricade. And this fundamentally changes their center of gravity. Instead of a low-impact roll, they are now pivoting their entire body weight over the top of the rail.
Which often leads to a catastrophic headfirst fall from a much greater height.
It's terrifying.
And worse still are the entrapment risks. Like a frail patient might try to slip through the gaps in the rails or slide between the edge of the mattress and the metal bars.
And their body slips through, but their head or chest gets caught.
Right, compressing the chest cavity or cutting off the airway entirely, resulting in mechanical asphyxiation.
Which is just horrific to think about.
It is. And it took decades of these mounting catastrophic injuries for the regulatory bodies to finally intervene. So now, the FDA and CMS classify the use of full-length four-side rails as a restraint in many contexts, precisely because it restricts voluntary movement while paradoxically making things more dangerous.
It's a complete inversion of the whole concept of safety, which kind of makes you wonder, at what point the law actually had to step in and force this change in bedside practice.
Hmm.
Because these strict CMS guidelines we have today, they didn't just materialize out of a vacuum.
No, not at all.
They were written in direct response to a massive institutional failure.
Well, honestly, the modern regulatory framework is basically written in blood.
Wow.
Yeah. I mean, if we bypass the 18th and 19th century asylum eras, you know, the straitjackets, the manacles, the patented cage beds.
Which is a whole other dark history.
Right. But if we just look at the American healthcare system in the 1970s and 1980s, you see a culture where physical restraints were just standard operating procedure.
It was just the norm.
Exactly. Government investigations during that era revealed that in long-term care facilities, anywhere from a quarter to over a third of the entire patient population was physically restrained at any given time.
Wait, over a third?
Yes, up to a third.
I'm just picturing an understaffed floor in a 1980s nursing home. You have, 2 nurses for 40 patients. If a third of those patients are tied into their beds or locked into jerry chairs with those lap trays they can't remove, that's not about complex medical treatment.
No, not.
That's purely a logistical mechanism to free up staff attention. It's literally just crowd control.
It was institutional crowd control masquerading as safety. And the sheer scale of this practice finally triggered the Omnibus Budget Reconciliation Act of 1987, which is usually just called OBRA 87.
Right.
And this legislation fundamentally re-engineered the legal landscape for nursing homes. It established a hard federal mandate, basically saying that residents have a legally protected right to be free from physical or chemical restraints imposed for discipline or staff convenience.
So it flipped the burden of proof.
Exactly. Restraint was no longer the default safety measure. It became a legally precarious last resort that required exhaustive clinical justification.
Okay, so OBRA 87 tackled the nursing homes, driving restraint use down into the single digits over the following decades. But that didn't fix the acute psychiatric settings, right? Or the emergency departments.
No, it didn't. The psychiatric side of the industry required a second, much more explosive catalyst.
Which was?
In 1998, there was a landmark investigative series by the Hartford Courant titled Deadly Restraint, and it exposed a terrifying reality across psychiatric facilities, group homes, and hospitals nationwide.
Oh, I've read about this. It was devastating.
They meticulously documented 142 restraint-related deaths over just a single decade.
142 deaths, and that's just within the scope of what they could actually uncover.
Right. The real number was likely higher.
And we aren't just talking about frail, elderly patients here. We are talking about adolescents, children, and adults who were physically overpowered and held down by staff.
Staff who routinely lacked any standardized training in crisis intervention or physical holds. You had patients tied to beds and left unmonitored for hours, or they were forced face down onto the floor by multiple adults.
Unbelievable.
And the fallout from this investigation was instantaneous and massive. It directly forced CMS and the Joint Commission to draft the extraordinarily strict federal regulations we operate under today, specifically 42 CFR Section 482.13.
And those are the regulations that establish the least restrictive alternative principle as absolute law, meaning, you cannot simply jump to a mechanical or chemical restraint when a patient becomes combative.
Right, you can't just tie someone down as a first response.
You have to implement and legally document a cascade of de-escalation techniques first, like verbal redirection, modifying the environment, or calling in trained crisis prevention intervention teams.
Yes. A restraint is only legally permissible when there is an imminent, undeniable risk of the patient causing severe harm to themselves or others, and every other less restrictive alternative has definitively failed.
But let's look at how this actually plays out on the floor, because if you have a chronically understaffed unit and say a patient has a known history of sundowning or becoming violently agitated at like 2 a.m.,
Which happens a lot.
a physician might naturally want to anticipate that, right? It seems entirely logical that they would write a PRN order, a standing as needed restraint order. So the night shift nurses have the authorization ready to go if chaos breaks out.
Well, they might want to, but writing a PRN order for a behavioral restraint is a direct violation of federal law.
Wait, really? A direct violation?
It is strictly, unambiguously prohibited. You cannot pre-authorize the restriction of a human being's fundamental liberty just in case they become difficult to manage.
Wow.
Yeah. If an emergency erupts and a patient becomes violently dangerous, trained staff can initiate an emergency restraint, but that action, instantly triggers a relentless, legally mandated clock.
Right. This is the 1 hour face-to-face rule.
Yes. Within a highly constrained window, usually 1 hour, a physician or licensed independent practitioner must physically arrive, look the patient in the eye, and conduct a comprehensive face-to-face clinical evaluation.
They can't just phone it in.
Absolutely not. They must assess the patient's immediate physical and psychological state, figure out the underlying cause of the agitation, and document exactly why the restraint must continue.
They have to assess why the patient is agitated. Like, is it a psychiatric break, or are they hypoxic?
Right.
Or do they have a massive internal infection causing delirium? The face-to-face forces an actual clinical diagnosis rather than just rubber stamping the physical hold. And even then, the authorization expires incredibly fast, doesn't it?
Oh, incredibly fast. The expiration windows are deliberately suffocating to prevent patients from being forgotten in these devices.
Okay, so what are the windows?
For an adult, the order expires in roughly 4 hours. For an adolescent between 9 and 17, it's 2 hours.
And for a kid?
For a child under 9, the order is only valid for 1 single hour.
1 hour. So a doctor must continually reassess and renew that order hour by agonizing hour.
Exactly. The entire system is engineered to make maintaining a restraint as logistically exhausting as possible for the hospital.
So they only do it if they truly have no other choice. But the legal expiration of the order is only half the equation, really, because the moment those straps go on, the physiological danger to the patient just skyrockets.
Yes, it does. Yeah.
We are looking at mandated, structured monitoring every 15 to 30 minutes, right? Sometimes continuous one-to-one observation.
Right. Staff must continuously verify peripheral circulation, checking pulses and capillary refill below the restraints. They're monitoring skin integrity, hydration, and toileting needs. But the absolute most critical metric they are monitoring is respiratory status.
Because the mechanism of death in these situations is rarely like a broken strap or a malfunctioning buckle.
No, almost never.
It is almost always positional asphyxia.
Positional asphyxia is a silent, rapid killer. In the 1990s, forensic pathologists like Donald Ray mapped the physiological mechanics of this.
And what did they find?
Well, when a human being is placed in a prone position, so face down on a bed or the floor, and any significant weight or pressure is applied to their back, it mechanically prevents the diaphragm from expanding.
The chest cavity literally cannot create the negative pressure needed to pull oxygen into the lungs.
Right. And as oxygen levels plummet, lactic acid builds up rapidly from the physical struggle, so the heart is suddenly starved of oxygen precisely when it is demanding it the most due to the adrenaline surge.
Which leads to fatal cardiac arrhythmias.
Exactly.
And the terrifying aspect of positional asphyxia, to me, is that it often looks like compliance.
Yeah, that's the scariest part.
Because if a patient's diaphragm is compressed, they can't scream. They might stop thrashing, not because of the DS. It makes total sense. And this physiological danger also explains why manual restraints, where staff use their own body weight and leverage to pin a patient, are classified as one of the highest risk interventions possible.
Absolutely.
Which kind of seems counterintuitive at first. Like, you'd think human hands are safer than locking mechanical leather straps to a bed frame.
You would think so. But a mechanical strap applies a fixed, quantifiable limit. A human being, on the other hand, in the middle of a violent altercation, is entirely uncalibrated.
Right, because of the adrenaline.
Exactly. Manual restraints occur during sudden emergencies. The staff members are experiencing massive adrenaline dumps. Their own fight-or-flight systems are fully activated. It is remarkably easy for an adrenalized healthcare worker to unknowingly apply lethal pressure to a patient's back or neck in an attempt to just secure a limb.
Because you can't standardize the force of an improvised human tackle.
No, you really can't.
So, okay, we have physical restraints, the vests, the bed rails, the manual holds, which present clear mechanical dangers to the airway and circulation. But the most heavily debated frontier in modern healthcare involves an entirely invisible mechanism of control, right?
Yeah.
Chemical restraint.
Ah, yes, the pharmacology of behavior management.
Right.
This is where clinical intent faces its absolute most intense regulatory scrutiny. Let's look at the ongoing crisis in long-term care regarding older adults suffering from dementia-related wandering and agitation.
Because for a long time, facilities were routinely utilizing powerful antipsychotics drugs like haloperidol or risperidone to essentially just sedate these patients.
Yes, they were using potent neurological agents to suppress behavior that was difficult for the staff to manage. But giving an elderly dementia patient an antipsychotic doesn't just make them, quietly sleepy.
It does a lot more than that.
It fundamentally alters dopamine pathways in an already compromised brain. The FDA ultimately intervened with a black box warning, which is their most severe classification, explicitly stating that these medications significantly increase the risk of death in elderly patients with dementia-related psychosis.
And we really have to look at the how here. Like, why is a standard antipsychotic suddenly lethal in a frail elderly patient?
Right, it's a good question.
It's not just a chemical timeout. These drugs can cause severe cardiac issues like QT interval prolongation, which can trigger sudden heart failure.
Yes.
Or they induce extrapyramidal symptoms like muscle rigidities and spasms. So an elderly patient might lose the neurological coordination to properly swallow, causing them to aspirate their own saliva or food into their lungs, leading to fatal pneumonia.
The physiological cascade is just disastrous. Therefore, if a facility administers an antipsychotic purely for environmental control, rather than as an explicitly documented, individualized treatment for an underlying psychiatric condition, it is a chemical restraint.
And CMS actively targets and penalizes that practice.
They do. But the debate isn't isolated to long-term care either. It is currently raging inside emergency departments across the country regarding what they call the chemical takedown.
Right, so imagine you have a violently agitated patient brought into the ER by police. They are tearing apart the room, presenting an immediate physical threat to the nurses, the doctors, and themselves. The team administers a rapid intramuscular injection of a sedative or an antipsychotic to neutralize the threat.
And the clinical debate centers entirely on where the line is drawn there. Is that injection a legitimate, emergent medical treatment for acute delirium or psychosis?
Or is it functionally a chemical restraint utilized to manage the room?
Exactly, which would legally mandate all the rigid documentation, the continuous vital sign monitoring, and those face-to-face evaluations we discussed.
So if it's a chemical restraint, the clock starts ticking.
Yep.
But if it's medical treatment, it's just a chart note. The entire legal framework hinges on exactly how the charting is phrased.
It really does.
But, let's apply some friction to this regulatory framework for a second. Because if we look at the immense pressure these regulations place on healthcare facilities, a massive trend has emerged where nursing homes and hospitals proudly market themselves as 100% restraint-free.
Right, they use it as a banner of ultimate quality.
Yeah. But doesn't establishing zero restraints as an absolute non-negotiable metric create a deeply dangerous environment?
How so?
Well, if a nurse knows that applying a life-saving restraint to a patient who is actively pulling out their breathing tube will ruin the hospital's perfect compliance score, aren't we incentivizing them to either use sketchy, unregulated alternatives or simply falsify the documentation?
Wow. Yes. You are identifying the core paradox of absolute metrics in healthcare. When zero restraints transform from a noble philosophy into a punitive administrative metric, it severely compromises clinical judgment.
It puts them in an impossible position.
It creates a massive double bind. Nurses and doctors must evaluate. Is a restraint the absolute safest, most life-preserving option for this specific patient in this exact chaotic moment?
And if the answer is yes, but the hospital policy is an absolute zero, the system essentially punishes the clinician for saving the patient's life through the only viable means available.
Exactly. It forces staff into the shadows, utilizing unapproved physical barriers or off-label sedation just to avoid triggering the official restraint algorithm.
It overrides the nuance of individualized care entirely.
It really does. The tension between preserving a patient's physical safety and protecting their fundamental autonomy is it's the daily tightrope of clinical practice.
And this connects directly to how you, listening, interact with the healthcare system as consumers and family members. When you look up a nursing home or a care facility to see their CMS star ratings, you are looking at data derived directly from these exact restraint laws.
Yes, the rates of physical restraint and antipsychotic administration fundamentally dictate those public ratings,
Which ultimately dictates reimbursement rates and drives family placement decisions. So this is not just some abstract medical debate. It is a live public policy mechanism that shapes the financial survival of these institutions.
completely interconnected.
So the object doesn't tell the story. The canvas vest, the metal rail, the haloperidol, they are inert. The moment human intent and the limits of human physiology interact with those objects, they become the epicenter of modern medical ethics and tort law.
That's beautifully put. And, consider the reality facing the system today. The regulatory frameworks governing restraints are more robust, punitive, and legally intricate than at any point in history.
They demand flawless care.
They demand flawless, deeply time-intensive, highly monitored care. Yet the environmental pressures driving the need for behavioral control like chronically understaffed units, an escalating mental health crisis, and a surging aging population suffering from profound dementia, those are all intensifying exponentially.
So the rules require infinite resources, but the system is running on fumes.
Exactly. When an immovable, punitive legal mandate collides with an under-resourced, deeply exhausted healthcare workforce on a medical floor at 2:00 a.m., the friction is immense.
Yeah.
We have outlawed the crude tools of the past, but we have yet to truly solve the structural crises that made those tools seem necessary in the first place.
It's a tension the system has yet to solve. Something to really think about the next time you walk down a hospital corridor. Thanks for joining us on this deep dive, and we'll see you next time.